This is the EKG review. And we're going to start by looking at the first page of the study guide. In the study guide, we have some pieces of the heart. You already expected to kind of know these, although they are important. Something that you do need to focus on is that conductional pathway, right? So we have how the electricity travels through the heart. And then we also have some rates of rhythm that need to be remembered, right? We have that SA node, and it's going to be kind of fast at 60 to 100. The AV node at 40 to 60, and then the NSG fibers at 20 to 40. The reason that you're needing to know these is because it correlates with what the EKG is going to look like in its different parts. And it makes it a lot easier to understand the EKG if you understand the different pieces. And then you also need to follow how to go through, right? Okay, we're pulling up the study guide. So I'm assuming you guys all got a study guide that you filled out during lab. Did you not? I'm sorry. Okay, you did. No, you did not. Oh, yes. You got one with a lot of strips, but not in lab. Okay, I really need to be able to pull this up. Give me just a second. I think I need to convert it because it's not. No, it is a PDF. Man, why is it not open? I'm sorry. Okay. Let's see if it shows up this time. Oh, yay. I think it's going to show. Okay. Please do. Oh, yes. Oh, yay. Okay. Oh, it's so weird looking, but at least it's showing up. Okay. This is what we're looking at. Let's see if I can't make it bigger. Just like a zoom in. Oh, there we go. Okay. Can everyone see this relatively well? Yes, it did click on the share button. It did not like the format of like every document on my computer. I don't know why, unfortunately. Yeah, I'm so sorry, guys. Okay, perfect. You can see it. Okay. This is basic arrhythmia recognition. This little study guide is so much of the information. This is like the meat and bread of understanding EKGs in terms of being able to read strips for the upcoming exam, as well as being able to read strips just in general. And then you're going to have more information in class, but that stuff is going to stay in class and be tested in class. So if you're worried about your exam tomorrow, make sure you're studying this and not stuff that is in like the PowerPoint for the class, because that's more detailed and it kind of hits it from a different angle. Okay. This one's not filled in, unfortunately, but we can all look at it together. Were you all able to fill it in or get a filled in copy? Did you guys get a filled in copy of this basic arrhythmia recognition? Okay, perfect. Okay, so I would just go through and like just make sure you know this first page, especially. This is mostly just the different parts of the heart, right? And then this part right here, this is the electrical pathway, right? And this is really important for understanding how this part, the EKG itself, works. because the EKG is actually an electrical like monitoring of the heart, it seems very scary to learn, but it's a lot easier than OB strips in my opinion. So at least that part's easier. When you look at it, oh no, don't be blurry. Oh man, I hope it's not that blurry. Okay. Well, when you look at it, this part is the P interval. Or it should be. PR interval. No, this is the PR interval. This is the P wave, right? So the P wave is when the atrium is oh, what is that? It's D like this is when the first part of it oh, what is the word? Not defibrillate, depolarizes. So it depolarizes right here, right? This is the atria. The atria is a lot of a smaller pump than the ventricles, but this part is the ventricle depolarization, right? And then the T wave is when it repolarizes. So this is when the ventricles repolarize, and the atrium also repolarizes, but it repolarizes in the same time frame as the ventricles are depolarizing. So you don't like actually see the atrial repolarization. Okay, so considering that,
It's right
what?
there, baby.
I'm sorry, could you repeat yourself? Okay, never mind. I'm sorry. All right, so that's like really good, just like basic information to know. I can send out a video on just reviewing that. And then what is the being able to actually look at a strip and know what it is a big thing. I'm sure you guys went over the 4 interpretive questions to ask when analyzing an EKG strip, which is what is the rate, what is the rhythm, regular or irregular, is there a P wave for every QRS, and what are the EKG intervals, right? And then you go through and you count. Each of these strips in here is a very nice strip. So it's going to be something like this on the exam, something that you're actually going to be able to read. Oh, thank you. Somebody put in depolarization. Thank you. You're so nice. Okay. Okay. So when we're looking at that, we're going to look at some different ones. I'm guessing you guys are having problems with some of the harder ones. So we're going to skip over and just kind of review what does it look like in general. Let me see if I can't pull up the rest of my study guide stuff. Okay. And then I heard yours are slightly in a different order than mine, and I'm so sorry if that's true. Okay. Let me see if I can't get I can't get this to show up. Okay. Oh, it cannot be inserted. Okay. It can be inserted as a document. Let's see. Okay. No, it timed out. Okay, it doesn't like that. Man, I wish I could just share my screen. But that was not working. Let's see. right. Oh, maybe I can share it now. Let's see. It still doesn't. Oh, there we go. Yes, please show preview. Okay, I think that might work. Why does it not like that? So mean. Okay, well, maybe I can pull emails after and send it out, but I have some old, like really simplified versions of looking at an EKG from when I was paying for Simple Nursing, and it kind of shows the outline of what it looks like in terms of not being quite realistic, but also showing the general idea a lot better than actually seeing it on a strip. Okay. How do I get that whiteboard to show up? Okay. So when we're looking at EKGs, right, what are we looking for? We're looking for those basic, like, first, the overview, like, does this look like a normal EKG, right? And then first we're looking at the rate, right? So how are we going to calculate the rate? We're going to calculate over a 6-second period how many QRS intervals there are, right? So start by counting from 1 to the next one. And on number 13 on mine, I have 1, 2, 3, 4, 5, 6, 7, 8 over that period of 6 seconds. Now, because we know 6 seconds, right, is times by 10 would make 60 seconds, we can change that by multiplying 8 times 10 to get the rate of 80, right? We look at how far apart they are and how evenly spaced. And wait, 80 is a normal sinus rhythm, right? Or it's a normal rhythm, right? Because it's not high and it's not low. It's between 60 and 100 beats per minute. So the SA node's working great with this. So we know that this is a good rate. We're looking at how far apart is it, and it looks like everything is kind of coming like soldiers, one after another, right? Boop, 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 boop. So we know that this is a regular rhythm. So we're gonna not have issues with it, like being irregular, going out of order. Okay, P waves. We see P waves. We see. I wish I could show this easier. Let's see if I can. Oh, there we go. Okay. Plus. Oh, sorry. Okay. So looking at this one, we still see that it has 8. 1, 2, 3, 4, 5, 6, 7, 8, right? You guys have all been doing this. We also see the P's right there. So now that we see that, we're going to know that P waves are present. And then we're going to look, is there a QRS? There is. Is it after the P? Yes, it is. And it looks like they don't need any therapies. So this is perfect. This is a lovely rhythm, right? Now we're going to get into some more weird ones like this one later. But looking at the overall shape, right, of these, is there some things that you know, I hope that were taught to you about how to look at different ones. So let's we have more people coming in. Okay. Let's start with something that makes like some sense, right? Hey, oh, you can't see? Man, how can you not see still?
So we can see like the document, but it's not showing like where you're at or if you're like what number you're on or anything like that. It's just the document itself.
Okay, that's really helpful. Thank you. I hate this. Man, I don't have problems like this with Zoom. I'm so sorry, guys. Man, what am I gonna do? Okay. This is not working then. Just because it's so big. Oh, I can share like a new one. See if I can't share part of it. Just so we're not looking at 17 different pages, not knowing what we're looking at. Okay. images. Not able to do unsupported file format. I don't know why it doesn't like. It's literally like a normal thing. Okay. I wish I would just show my screen. Let's see. Could somebody send me? Does anybody in here have my email? Okay. Can someone volunteer? I'm gonna give you my email, and you can send me the one that you have, so we have the same. We have the same file that has like the same numbers, so then I can just tell you which number we're looking at. Thank you guys. You're the best. Okay. 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 Let me pull that up. Okay, perfect. So first one, normal, right? Okay, yay! Oh, thank you so much, Alexandria. Okay. So when we're looking at the different rhythms, the first thing you want to do, obviously, was like do all the steps, but it's good to know kind of like an overview idea of like what does this look like, right? So your number, let's see. Okay. Your number 17 is an atrial flutter, right? Atrial flutter is known for being sawtoothed. And when looking at this, this is one of my favorite ones because it's so distinctive. Do you see how there's like really pointy, like little tiny peaks that are all exactly the same right between all of the normal QRSs, right? This is very like, if you were to zoom out, it looks like you could put this on like a board and you could saw through like, you know, some sheets or something, right? This is a very just recognizable rhythm. It's not a good rhythm, and it depends on like what the rate is going at, because it can end up being something that ends up going to atrial fibrillation because it gets faster and worse, and then that can cause you to have issues with clotting, and you can end up with like a clot, or it could go to ventricular stuff, and then that's no good. Okay, so I would know anything they have written in here in terms of like what to do. Okay, but when you look at it, it's like it's very recognizable, right? Okay, let's see. But now above it is atrial fibrillation. Do you see how atrial fibrillation has a lot less wave format? Like it's a lot smaller, and there's no distinct P wave, right? It's just kind of very messy, and it's definitely not flat like it's supposed to be. And there's not really a break either. Now you still have the distinctive QRS waves, right? And that tells us that the ventricle is working properly, but we do have that sort of what is that, like uncorrelated extra stuff. I'm so sorry. Your computer is working just fine. I cannot figure out for the life of me how to share the study guide and be able to like point through it. I did figure out how to share it just in terms of like small sharing, but it wasn't working very well. I can try pulling that up again though, so you have it. But I'm just gonna keep going through without it and have you guys look at your study guide on your own. I'm sorry. I don't know. I guess I just don't know Teams as much as I thought I did. And I'm sorry. I'm used to Zoom. Okay, so we're on number, let's see, number 16. Number 16 has both a atrial fibrillation, and then number 17 has the atrial flutter. Atrial flutter is very sawtooth. Atrial fibrillation is very like just wavy, but inaccurate, and there's no distinctive P wave, right? These ones are really easy to pick out once you have just looked at them enough. But also another thing is noticing how regular and normal those QRSs still look, right? We're not getting that nice like deep downward spike on the atrial fibrillation, but we're still getting some nice QRSs, right? It says QRSs. Oh, QRSs to Ps are not applicable because there's not really a transition there. All right, those are easy ones to pick out. Okay, what should we do next? Let's see. 14 is just very slow. That's a normal one though. That's going to be easy to pick out. Normal sinus rhythm. 15, you're looking at it and that T kind of looks big. The big thing here though is you're going to look at how often are we having it. So you count 1, 2, 3, 4, 5, 6, 7, 8. And this is over that 6-second period. We're going to double check by counting those boxes. And we're going to know that that's a rate of 80 because we times it by 10, right? Rhythm is regular because our soldiers are coming one after another. They're not out of sync. Some ways to help you if you're like struggling with looking, is it regular, is it not regular? Like if you can kind of like cross your eyes and look at it, it kind of takes away like all the extra stuff, or just kind of like trying to look at it as a whole, like either just like blurring your vision, just trying to see, does this look very regular? And it does look regular. There's nothing out of sync. Let's find one that does have something out of sync. Where's one that just kind of comes early? Okay, so 26 is a block. But you can tell looking at it, it has that big missing space, right? We're looking at it, we're like, what's going on? Well, that's where you have a missing type thing where it's dropped a QRS, right? And so when you blur your vision, you literally cannot, you can like see there's a missing soldier right there. So we're just looking at that. We don't see that there's a missing soldier. So we're going to go back up to, where were we at? We were at number 15. So there's nothing missing in this one. So we're going to know that it's normal just by like deduction, right? With number 16, obviously something's wrong. We're going to remember that we see our normal QRSs, right? So it's not something wrong with the ventricles because the ventricular contraction looks good. It's definitely something wrong with the atria because our P waves are like basically absent. And so we're looking at what is that. So with the rate, see how it's, when you blur your vision, it is irregular. Like those QRSs are not coming one after another. There's a big like blank space kind of early on in that EKG. And so the rate is variable, but also we're having problems with that P wave, and that's making it indiscernible. And that's to the point where we know that it's fibrillating instead of depolarizing and continuing into the QRS wave. That atria is like contracting, like it's just like vibrating, and that's what's causing oh yes, please do the survey afterwards. Okay, so that's just causing it to look very sporadic, which makes sense if it's fibrillating. If it's just quivering there, it's not going to make that full nice depolarization. Okay, and then 17, that's the atrial flutter. It's still better than fibrillation, but it's still no good. And when we're looking at it, the big thing that we're noticing is it looks like a sawtooth. Like if you blur your vision a little bit, you literally like can still see it, and you could put that on a saw and saw through a board, right? Now this one's not good. Neither of those are good. I already explained that. But the level of bad is different. And another thing for atrial fibrillation, like when you're studying for the NCLEX, also remember that this not only can go into it can go into ventricular issues and cause the ventricles to be to end up not working properly, right? Which is why we need to cardiovert it, but and give like antiarrhythmics. But it can also be a bad thing to have just in terms of the atria not contracting well enough to get the blood out. So the blood's circulating in there poorly, it can end up clotting, and then if a clot is squeezed out, it can go to your brain or your lungs and then end up giving a lot of damage. So we're gonna want to treat that. Okay. 18, but people can live in atrial fibrillation. It's really interesting. Okay. Number 18, supraventricular tachycardia. What is this? It's really fast, right? You can tell that just by looking at the strip. We're going to make sure this is still a 6-second strip. And if you count it, you're going to get 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. That's a very fast rate, right? So fast. Is the rhythm regular? Looking at it, it is, yes, it's very regular. Now I should count the boxes. Sorry, I haven't been doing that. But if you count the boxes, you're going to get also a very regular look. If you just look at it overall, still it looks very one after another, right? Soldier, soldier, soldier. This is regular. P waves, you can't see the P wave. Now it's hard to tell, is this a P wave or is it a T wave, right? It's both. It's the depolarization of the Q. It's also the repolarization of the T, right? I believe that they call it a T just because typically the T is bigger, and so it's like the P is being overtaken, right? QRS, yes, we definitely see that. We still see that. So basically, the biggest thing here is just that it's super, super fast, which is also not great. We're gonna treat the underlying cause, like maybe they're on an upper drug. So maybe they're on something like meth or something. I don't know. I'm making up a story here, but whatever's going on, it's making this heart very fast. You're gonna want to treat that. And then you also want to give them some IV fluids because maybe they're hypovolemic. And in terms of hypovolemia, you can end up with really bad tachycardia. Okay. Number 19, what are we looking at? Well, first off, when we look at this, we're seeing something really crazy, right? What is going on that's making the like weird inverted T wave? Or QRS, I mean. Well, it's an irregular rhythm for sure. The rate is still 1, 2, 3, 4, 5, 6 because we're only counting those normal ones, which would be like a good contraction. So this rate is 60, so it's still normal, but like barely. But the rhythm's irregular. Like looking at it, there's missing inverted soldiers going on. Like there's a monomorphic PVC going on. So monomorphic means it's coming from the same spot because mono means one, and so preventricular contraction. So before the ventricle is ready, it's basically contracting early and ending up looking really weird. But it looks exactly the same. Like if you were to copy the first one and try to paste it on the other one, it might work, right? That means we're seeing it in the same exact spot in the heart. So it's coming from like one specific area. And because it's doing exactly the same thing over and over again, it's a monomorphic one because it looks exactly the same and it's coming from the same spot. Okay. So we're going to treat this if the patient is symptomatic. So if this patient is like struggling is feeling really dizzy or something, then you'd want to treat it. If not, don't treat. I don't think, just looking at this, maybe Dr. Kirkendall is still here. But I don't think that you're going to have to know how to treat this unless there is something that you need to know on that. It doesn't say on the study guide. Okay. I'm just gonna go with that. That is, I would just go with the study guide. Okay. Number 20. Number 20 is crazy. There's a lot going on. What they're really trying to show you is a bunch of different PVCs. So these are good to know just in terms of like what are you looking at. Did you guys get to hear the funny story about PVCs? And if somebody could type that in the chat, if you got to hear the story about PVCs. Or, oh, what is it? Maybe that's not the story. Maybe it's a story about, I think it's actually a story about, blocks. It's in the PowerPoint. There's a story on blocks, I think. I think it's on blocks. Yeah. Okay, it's about blocks. So never mind. PVCs, you just kind of have to know them. Sorry. But looking at it, right, you can tell based on how many are going. So what it's showing in 20 is couplets, like 1, 2, like they're twins. They look pretty much the same too, which makes them really easy to pick out. Triplets, you see that 1, 2, 3. That shouldn't be hard to figure out. See how they're all the same weird thing. But they stand out very well. So that's triplets. Let's see. That's a really bad strip. Okay. Unifocal PVCs. So unifocal, so like they're all coming from that same spot again. And it looks like it's just that one coming after that normal beat. So it looks exactly the same. Again, we could copy and paste it. And then multifocal is next below that. And see how they all look like different? Like there is one in the beginning that PVC looks the same as the third one that happens, but it does not look the same as the second one. But we know that those are all PVCs in terms of that they're looking like very wide, or like sort of wide, but still there, but strange looking ventricular contractions where the ventricles contracting basically too early and ending up like with a like weird looking QRS stage. Okay. I'm looking at your PowerPoint really quick, but don't go over there yourself. AFib, aflutter, supraventricular tachycardia, PVCs. Okay. So in this like one, you see how it looks different on the slide. I think these are the same. Sort of. Okay. I'm so sorry. I forgot what the difference is between unifocal and bigeminal, trigeminal. Is C. So I'm gonna have to look that up and get back to you guys. Multifocal is really easy because that means it's just coming from different spots, right? So with multifocal, they're gonna look different. It's gonna be the same thing, right? It's that funny looking like still there, like you still have your peak and you still have your plummet, but it's just they're like wider, but it looks different. Both of them look different, which tells you it's coming from a different spot, right? So with that, you know then that it's coming from a different spot in the heart, so there's more than one going on, right? And then with the FFPVC triplets, you can see triplets really easily. They come one after another, right? And couplets come as like twins. So those ones are really easy to look at. I'm gonna have to get back to you on the bigemini PVCs. Okay. Now looking at 21. 21 is monomorphic VTAC. This one should be really scary because this one's just basically like really bad. So looking at this, we really can't get, I guess we can get a rate, huh? So when we're looking at the rate, we're going to look at counting to make sure that we get this right, right? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So we're counting each one, right? From 1 to the next one, we get 8. But that's approximate. You could also do, like, I kind of feel like this is more like 70 just because that first one's not totally there. And so we do have a rate. It's not a good rate though. Okay, and then it's rather regular, right? So if we were to look at this as an overall strip, it's coming one after another, right? Very regular. That's nice. But there's no P waves. And we know this is a QRS uh, because it's so big. Comparative to like a P wave, it'd be tiny, and it would make it more of like we'd get like a funny looking one, like the atrial fibrillation, where it's like, ugh. But this one's very big. Now, do you see how these look like gravestones? That's the best way to remember this, in my opinion. It looks like literal gravestones. Ventricular tachycardia looks like gravestones, and with that, it is really a bad thing to see. So you can kind of think of this as like a tombstone pattern because of how bad it is. You're going to want to look and see if they have a pulse. If they have a pulse, you're going to cardiovert them and synchronize first. So if they do, then that's good. If they don't, if they're pulseless, then you're going to defibrillate them, which is like bigger, right? It's a bigger a bigger deal, but that one's like either of those, no good. You need to get them out of that like fast, right? Because if they could die, which is no good. What are you gonna see this caused? It might be after like a heart attack or like hypoxia. And it also could be from a low potassium or a low magnesium. So understanding like this could be something that also needs to be fixed electrolyte way. Remember, potassium affects the heart a lot, so it's important to remember it. Okay. VTAC no pulse, defibrillate. VTAC with pulse, cardiovert. Pulse makes it better than no pulse, right? So that's a good thing to remember. Now looking at 22, this is monomorphic VTAC or torsades de points. Look at how crazy it looks. Do you see that? If you were to try, like I know you probably heard like it called like a streamer. Because the more you look at it, like if you just kind of blur your vision, I really wish I could pull up the like simplified one. I think I'm gonna try to send that out to everyone. But points to sods is one of the easiest to recognize once you know the other ones, because once you know the other like EKG strips, points to sods is gonna stand out as like this crazy thing. See how it's using like almost all of the strip? Like it's way up here, and then it like literally does like a flip, and it's way down at the bottom, and then it's way back at the top, and then way back down at the bottom, right? It looks like a streamer. So when you're looking at this, it's polymorphic, so it's got a lot of different things going on, but it's polymorphic VTAC, so it's coming from many different places, and it's way too fast. So we're not going to try to count a rhythm on this because of just not being able to really tell exactly when is it a QRS, and especially in the smaller spots, I can see a couple where I'm like, well, what is that? But remembering points to sods is like kind of a fun way of remembering it. But it's coming from a lot of different places, so instead of looking at that like that gravestone, it's looking like a streamer that's using up the whole board. It looks like you're not expected to know a therapy for that. I wonder why. It might be that you're expected to know it just in terms of like monomorphic. Let me see if I can't pull up my other thing. Oh, I already have that one up. Yeah. Okay. In terms of knowing like what causes this, it is something you can see post like a heart attack, so MI, or hypoxia, or this could be low magnesium. A good treatment in Clark's tick is it could be magnesium sulfate. as an issue, so you'd want to give some magnesium, or it could be a low magnesium, so you might want to give some magnesium sulfate. Okay. Going back to our lovely outline. Where is that? Okay. Okay, so now we're going to look at 23. 23 is ventricular fibrillation. This is very coarse, though. So the TAC had the gravestones, right? Ventricular tachycardia. The fib, this one's coarse, so it's got more I guess more texture than a fine V fib would have, but it's still, so if you know, monomorphic VTAC looks like gravestones, and polymorphic VTAC looks like a literal streamer where it's almost touching the top of like the EKG, and then it's way down here almost touching the bottom, and it's way up here, right? And it's literally like flipping. When you look at 22 versus 23, you're gonna notice that 23 is not flipping in the same way. It's not doing this crazy like whoop whoop whoop, and it's not using up most of the EKG space, right? It's not super exaggerated like points to sods, or towards sods to points. So instead, it's fibrillating, right? You're gonna get that more like fine, like woo, and with that, the heart's not doing quite as like crazy motion, but it's still getting like that the like right, and it's not got any of the normal QRSs right in it, and it does not look like a sawtooth pattern in the same way that atrial fibrillation looks like a sawtooth pattern. This one is just kind of crazy. There's no distinctive QRS like waves, and there's no like break for a P. There's none of that, and it's not taking up all of the board like polymorphic VTAC, but it is a lot more than a systole. So looking at therapy, we're gonna give high quality life support. So we're gonna like start doing breaths and all of that, and you're gonna want to determine underlying cause. So we're gonna look at like what are we gonna do to fix this? Is it maybe some sort of electrolyte problem, or what's going on, right? And then try to fix it as fast as possible. Let's see if I have one on that. That's the same one. Okay. Okay. Where did it go? It's not that. Not that. Sorry, I have a lot of things open. Okay. Now going back to let's see, 24. 24, this is a systole. You're gonna notice though with ventricular fibrillation, that one's coarse. You're still seeing like a lot of movement, right? A systole is the only one where you're not gonna see like basically anything. Now obviously like you're gonna get like a little like tiny, you're seeing like a little bit here, but see how it's mostly flat? And I'm not gonna ever want to call that tiny little like, it looks like there's kind of like a little bump, but that's really not like, that's not a excusable QRS or P or anything. Basically saying like nothing's happening. And you can see like it drops off, so there's like something in the beginning, but that's like the end of whatever, and then it's falling into a systole, and by the time we're leaving there's a systole too. So there's definitely no rate here, there's nothing to count. There's no rhythm because there's nothing coming to look and see if it's coming even regularly, and there's no P waves. Now looking at this, right, you might think, well, is that little tiny blip a P wave? It's really not. A systole is not going to ever be like super extra, very straight like you see like in the movies. It's not necessarily going to be like that. It's more of like this like fluid line, like if you had like a piece of hair fall or something. Like it's just it's flat, but it's not going to be like flat, like flat necessarily. Okay. And then obviously there's no like P to Q or S, so there's nothing to do here. Now, if you're wondering about the P waves, I would just remember like these aren't P waves. We know that because it's asystole and because asystole doesn't need to be flat. But you also won't see P waves without like you shouldn't really see like a strip ever where you just have P waves and there's nothing else on there. Like in terms of like there's like just open space. Like you're probably not going to see that on the test. So if you ever see like something where you're looking at it, you're like, that could be asystole, or it could just be a bunch of like nothing but a couple like P waves. Well, there's really not going to be any of that. Okay, high quality BLS. You're going to want to follow protocol for ACLS. You determine and treat underlying cause. This is one of the most deadly rhythms because there's literally nothing going on. Okay, 25. 25, this is a first degree AV block. This is, you guys did get to hear that cute story. I feel like the story really helps. After I heard the story, it was a lot easier to remember the differences between the blocks. But to start, basically, you're going to look at, with 25, what is the rate, right? 1, 2, 3, 4, 5, 6. And there's 6 of them. They're all within, I'm going to double check. Okay, 1, 2, 3, 4, 5, 6. Sorry, I'm counting boxes. 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Okay, so this is like we know that we can look at like a 60-second strip and then or a 6-second strip and times it by 10, right? So we can times these 6 by 10 and we're going to get a rate of 60, which is slow, but it's not slow enough that like it's on the low end of normal. So still a normal rate. So it's not bradycardic. The rhythm is regular because if we look at it from an overall standpoint, there is a very regular amount of space between each of these. And they're coming one after another, right? Like soldiers. Boop, 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 boop. Okay. P waves. We're gonna see there's that crazy, like it looks like there's more of a space, right, between the P and the QRS. Let me look at what we were supposed to calculate that out as. But basically, like there's more space there. It just looks like that's the only thing that's kind of standing out. This is why you need to count, but that PR interval is like longer, right? But there are P waves, so we're gonna get yay, there are P waves, and then P to QRS. There is a QRS, that's good, but there's a longer period between them. So let's count and make sure that we know how far apart it is, because when we're looking at counting, that's when we can determine is it officially or is it not officially an AV block. The first degree is where it's not. The first degree is where it's not coming as fast, right? So they're still communicating. It's just that it's slower. So when we're looking at where is the sorry, I have a lot of things open. Okay, don't need that anymore. Need that. Okay. PVCs, forced ventricular okay, asystole, pulses electrical activity. Oh, we should talk about that in a minute. Okay, first degree AV block is slide number 48 in your slides. When you're looking at this, PRI is less than 0.2 seconds. Rhythm is regular, rate if underlying rhythm. QRS is usually normal. Okay. So when we're counting those little tiny seconds, right? We're counting from the beginning of the P wave to the beginning of the R. And we're counting those tiny boxes, right? 1, 2, 3, 4, 5, 6, 7 almost. On the little slide. Okay, so let's go back to ours. Where's ours? I'm going to count them. Where is where'd it go? Let's see. I don't need that anymore. Oh, okay, here we are. Okay, 25. We're looking at this, and all we see is that we have a prolonged period between the P and the R interval, right? If we count. 1, 2, 3, 4, 5, 6. So it's about 6, right? And I think that's about like the same actually as what we have on the slide here. But we know that that's too much, right? Just looking at it, we know that that's too much. So we're going to know that there's something a little bit off there. And because of that, we can go, okay, there's a block, right? Now, is it first degree, second degree, or third degree? Well, we know that it's only first degree because we see that every P wave has a QRS. And they're all at the same distance apart, right? When we're looking at the distance, and we can count multiple, you'd want to do that on the exam. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6, 6.5 kind of. You're getting the same number of little tiny boxes, right? And we know that that's more than what you're supposed to have. So we know that there's a continued block here, and it's the same, like it's continual, like each soldier, although not ideal, each of these contractions is doing the same thing. So we're going to say that this is a first degree AV block. The P wave has a block between it and the PR, but they're still talking. Okay. And so we're not going to give any therapy unless the patient is symptomatic. So if the patient's struggling to breathe or anything like that. They feel like really lethargic. Okay. 26, though, is a second degree type 1. Okay. So we're looking at the rate, and we're going to count between how many QRSs we have. 1, 2, wait, what? Something's wrong. There's like one missing, right? 1, 2, 3, something's gone. So we're going to say the rate is variable because we don't know when these ones are going to fall out, right? Because we don't have enough information to know when they'll fall out. We don't know what to do. Now, this looks like this could be what you might like confuse us for, might be like a triplet, but remember, triplets are more like they're not gonna have like a missing P over here. See how there's a missing P wave? So when we're looking at this, we have we start our strip with a P wave, and then there's nothing, and then we have another P wave, and then we have a QRS, and then a T, and then a P, and then a QRS, right? But then we get to about like the middle of the strip here. There's another P, and it's missing a QRS. So that's a classic sign of a block, and that means that we're missing that QRS. Whereas with triplets, you're going to see like the whole thing, but they're just kind of weird, right? And then also they tend to be like that weirder, longer look, and they're going to look exactly the same, right? And they may not have like a distinctive P that you can stand out with the triplets. But with this block, you're going to definitely see some P's that are missing their QRSs. And we know that the rhythm is irregular because we can't define when it's going to drop out again. So we can't define a rhythm out of this 6-second strip. You would be tempted to say it could be a 60-second. That's not true, though, because we don't know. We're trying to predict the whole minute, right, for a rhythm. And because we don't know when it's going to fall out again, we can't use this as information that's acceptable to decide what their heart rate would be and what the rhythm would be. So we're not going to be able to say that. We're going to be able to say only that it's variable and irregular. We're going to say that there are P waves because we can see very distinct P waves. There's that T wave, and then there's definitely another wave. So that has to be a P wave because the ventricles are already repolarized, so that must be the P wave depolarizing. Okay, P to QRS. We see a drop to QRS. It's very clearly there's twice, right? So what are we going to do? It depends on the patient presentation and symptoms. Sometimes they need chronotropic medications. Okay. That's different. There's a type 2. And let me go and make sure that I'm telling you correctly on this. Where is that? Okay. Okay. There's Mobitz 1 and there's Mobitz 2. Okay. What is the difference between type 1 and type 2? Type 1. Oh, I was reading. Okay. So with type 1, it's getting longer before it drops, and with Mobitz type 2, it suddenly drops. So we're going to want to make sure that we're also counting the P waves, and the PR interval, I mean, and let's see. With this first one, 26, it's really easy to like not look, but if you look, you're going to notice this P wave is on time. Then the second one is long, and the third one's longer, and the fourth one it drops, right? So if we're just counting boxes, a couple of these definitely qualify for at least a first degree type block, right? Because we're seeing too long of a PR interval for it to be acceptable as a just normal rhythm. But the fact that one is missing tells us this is a type 2 degree block because we already dropped the QRS. So with type 1, we get some like warning, right? 1, 2, 3 is super long. Wow. And then 4, it's gone. With 27, you're not going to get that. You're just going to see that you have two things going on where you have that P interval going and then the T the P wave going, and then you have your QRS going, right? Because they're somewhat like separate in terms of they're not really communicating like they should. It results in a different ventricular and atrial rhythm. So there's still some like correlation, but you're just gonna see that it there might be a fixed relationship, but it's on its way to a full heart block for sure. They're starting to like not really pay as much attention to each other, right? But the QRS is still coming after a P, which is good. But we are seeing some that are dropped, right? And it's not so great. Okay. Main's consistent, but QRs are dropped. Okay. So 1, 2, 3, 4, 5, 6, 7, 8 P waves for atrial, right? And then for ventricular rate, 1, 2, 3, 4, 5 is what they're counting as the rate here. Now, I would also say that sometimes this rate would be hard for me to calculate. But I wonder why this one's not variable. I actually don't know the answer for that. I'm going to ask on that, and then I'm going to get back to you. Okay. The rhythm obviously is irregular. That makes a lot of sense, right? If we look at this, they're not coming one after another. There's like missing QRSs. Very bad. Okay. The P waves are present. We can see those P waves. And then we see dropped QRSs, right? Some of them are not there. So this one's like going to be more of a pacemaker situation. You're going to give chronotropic medications. That makes a lot of sense, right? Just in terms of this is not a sustainable rhythm. And you could like end up losing something. Okay. Now, third degree block, that's the one that's like really bad. Now, looking at it in 28, you can really tell that everything is doing its own thing, right? You have like what looks like an inverted QRS. You have some missing QRSs where there's like nothing. And so we're going to start by looking at our Ps, our P waves, and noticing that they are coming very regularly on their own. Like if you were to take out the QRSs, you just get these very regular blips of Ps, right? Like boop, boop, boop. They're doing their own thing, and it kind of really doesn't matter what the QRS is doing. Now, if you'll note, there are a couple that come right after. I see one that comes right after a QRS, and I would be tempted looking at this to count that as a T, but I know it's not a T because it looks exactly the same as the other Ps. Does that make sense? So because we know that they look exactly the same, we're going to count that as a P wave. So in counting that, atrial rate 1, 2, 3, 4. I feel like there's one, like if you were to follow this pattern, because you can, because it's really very regular, I think you can count this as well. In terms of, you should be able to count the intervals, and let's try doing that. 1, 2, between the first and second P wave, I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, like 14 between the beginning of the first one and the beginning of the second one. So let's see what's between the next two. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 13 between the first and the second one. Now it could be arguably like 13 and a half. So it's really like close. Let's see what's next. Ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 again. And then if you continue that, right, we're seeing that it's the same, right? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Now it's 13 is hitting in the middle of this QRS, right? Which tells us there's probably a P inside of here, especially if we can continue counting and we get another 13 before we get this next one. So let's see. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Ooh, I might have started on the wrong one though. So there's definitely a missing P that's hiding inside of this QRS. Doesn't mean that it's not happening though. It's just hiding because we still can have our atria depolarizing while our ventricles are depolarizing. So I'm going to count that as well as hiding, and then I'm going to count to the next one. 1.5. So 1, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 again. So with that, we have 13, right? So now looking at this, we can confidently say that there is a very regular pattern between all of these P's. But then we have missing QRSs. And we definitely have a QRS that's happening right on top of another P. And it's just like, it's kind of happening whenever it wants. We have a really, really long PR interval happening here in the middle, and then a really short one happening only shortly after, right? But the difference between this and a type 1 block, because a type 1 block gets longer and longer, well, we can see some like longer and longer happening here. We know that the P and the QRS are not communicating because the P is communicating only with itself. And it looks like, although it looks like we have like one that's shorter and then longer, really we have one that's shorter, kind of a PR interval is probably like not ideal, but still like more normal looking PR. And then we have that really long one. And then literally inside of that same contraction, we have another P hiding, and we have another P. So this would not fall into that like longer than dropped. It falls into the, they're literally not communicating. So they need different rates, right? So for A1, 2, 3, for atrial rhythm, we have 1, 2, 3 PR, 4 Ps, 5 Ps, 6 Ps, 7 Ps. And I'm counting that one that's inside of that contraction because it's still existent. I just can't see it, but I know it's there, right? So that's 70 for the 60-second strip. Sometimes you get by 10. And then ventricularly, I've got 1, 2, 3, and just got that fourth one there. So because of that, I can count this as 40 for my ventricular rate. because I'm timesing it by 10. And is the rhythm regular? Strangely, yeah, it is, because they're not communicating with each other and they're all regularly doing their own thing, right? So those P's are very regular. They're coming at about 13, right? 13 to 14. And QRS's, QRS's is also normal and regular. Let's count those. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32. Okay, now let's go on to the next one. Ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Oh, I got messed up. Okay, I'm going to just kind of round. 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32. All right, and then let's count again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32. Okay. It's okay if you get slightly messed up in your counting. They're not going to be nitpicky to the point of that being an issue in terms of it's really hard to remember which one you're on. Even with your mouth sometimes, but we're getting 32, right? So we know that these are coming at a very regular rate. It's their own rate, and it's not the same as a P because they're on top of a P, but it's still its own thing, right? So we can still count that this is a regular thing happening, and that 1, 2, 3, 4, it would continue like this, so we're going to get a rate of 40 for the ventricles. Okay, so this is a very regular rhythm. We see P waves, we see QRSs, although some of them are kind of missing, but we don't have a P missing in terms of they're just not where you expect them. But P to QRS, no, they're not correlated. So this needs a permanent pacemaker because this heart is totally not listening to the different parts of it and not listening well. You need a pacemaker that's going to act in such a way that allows it to make sure that the heart will have one rhythm. Okay. Yeah. Okay, it looks like there's a few more. Okay. After 28, it looks like there's a new page that just has some different ones that you can look at. Second degree type 2. Remember, type 2 is where it gets longer and then drops, I think. Is it getting longer, though, really? Let's see. It's clearly getting longer. Okay, wait. Okay. Where is that? I just lost it. Okay. Second degree type 2 block. So we're going to first look at what is our rate, and we're missing some, and it's kind of confusing in terms of what's going on here. But I'm going to need to ask why we calculate the rate on this one. But if we do that, then we're going to get 1, 2, 3, 4, 5, 6 for ventricular, and 1, 2, 3, 4, 5, 6, 7, 8 for our atrial. But I need to check on why you're sometimes calculating versus not always calculating that, because I'm not sure. So you're gonna need to ask on that. I'm sorry. Okay. But we know that this is a type 2 block, right? And we know it's second degree because we're literally missing some. They are communicating because we do see that they're coming one after another, right? Or that we are having our PQRSs, our our P's are coming before our QRSs, and our QRSs are coming after P's consistently, and they're not doing their own thing. We just see that some of them are missing, which is not so great. And that's kind of an issue. Okay. Let's move on to VFib. This is coarse. We know that it's ventricular fibrillation because it is there's no normal QRSs in there, right? So the ventricles are not contracting well. There's no QRS like big shot up or down. We note that it's not looking like a streamer, so it's not points to sods towards what is that called? It has another name. Polymorphic VTAC. This is not polymorphic VTAC. We also know that it's not monomorphic VTAC because monomorphic VTAC would look like a gravestone, right? But it is coarse fibrillation. It's got that looks like quivering, but it's bigger than what it would look like if it was atrial. And with atrial, we would also still have those QRSs, right? No, you can leave it alone. Okay. So we're not going to be able to calculate a rate from this, right? Because there's not really a rate to calculate. But we are going to note that it looks like a lesser version of the streamer, and so therefore we know it's VFib. There's no regular rate, there's no P waves, there's no QRSs, and that's just going to leave us with that this is just simply a coarse VFib. Okay. Second degree type 1. This is the one where it gets, oh, sorry, I shouldn't read it off first. Okay, looking at this strip, what do I see? I see that there is definitely a missing QRS, right? You can see that just by looking at it with, is there a, like a normal rhythm? So first, is there a rate? Yes, I think there's a rate, but then there's not really a rhythm, because or there's like a missing one that makes our rhythm messed up, right? It makes it so that there's not really a soldier after it. So noting that, I'm not going to know why until I look at my P's, right? Well, looking at my P, I note that this first interval is 1, 2, 3, 4, 5, and the second one is 1, 2, 3, 4, 5. Wait. Oh wait, no, I'm counting the wrong one. I'm so sorry. Okay, I'm gonna note that the first one is 1, 2, 3, 4, 5 and a half. More like 6. Okay, the next one is 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6, 7, 7 about. Next one is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And look at that. It's literally like this third one here is literally like 2 big boxes. This is way too long as a P wave, right? We know that this is like super not great. There's definitely a block going on here. What's going on? But then we know like also, right, that it's getting longer because we went from like 6 to like 8, and then we went to like this 2 box thing, and then we don't have a QRS after this, so we know that this has to be a second degree type 1 block. And then if we want to keep checking to make sure this is the right thing, we're going to count the next P wave. Ready? 1, 2, 3, 4, 5, 5.5-ish. Okay. And then the next one is 1, 2, 3, 4, 5, 6, 7, like 7.5. Yikes. And then the next one, we can't see that. So it's definitely getting longer, right? So we know that it's setting up for another one, and we can confidently call this a second degree type 1. Okay. Now looking at the next one, without looking at what it is, we're going to start by what's going on here, right? Well, does it have a rate? To me, yeah, it looks like it has a rate, right? So let's count the rate. 1, 2, 3, 4, 5, 6, 7. This is in a 6-second strip, so it's about 70. How do we know that it's atrial ventricular block? Just because we're having that prolonged interval is what we should be seeing. Let's see if we see that. Yes, we do see the prolonged interval. Okay. When we count 1, 2, 3, 4, 5, 6. Let's count over here. 1, 2, 3, 4, 5, 6.5. That's pretty long, and we know that by that there is some sort of block. Now, like we're looking at it though, we have a QRS for every one of them, right? We're still getting our QRS. We still have a T. So we still have like this normal rhythm, and there's none that are dropped, and it's not getting larger. Like if we count 1, 2, 3, 4, 5, 6, we get another one over at the end here. They're not really changing in terms of like how long the block is. It's just that it's long. So therefore, looking at this, we're knowing that we can get a rate. It's got a rate of 70. We can get a rhythm. It's very normal. And we see P waves. That's good. But then when we're looking at our PQRS, we note that there's an elongated PR interval. That is indicator of a first degree block, as it's not getting longer, it's just staying the same. All right. Now looking at this one should be really easy for you to look at. This is the first one on this page. What is this page? It just comes right after. It's the second page of the extra ones to do. Looking at this, what do you see? Gravestones. So what should that tell you? That should tell you that that's monomorphic VTAC. It should be a very distinctive rhythm for you because it literally is the one that's just a bunch of like waves, right? We can count a rhythm for this if we want. Let's count, or a rate for this. Let's count the rate. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, maybe 16, but more like 15. So this is 150 because we're timesing it by 10 to make 150. So we have a rate of 150. That's very fast, right? That is tachycardia by all means. Now we're going to look at, is there a regular rhythm? Yes, there is. This is coming one after another, right? We're seeing that happen consistently throughout this whole strip, and we're not seeing any real change in the way that it looks, right? And we're seeing a very like monotone look. There's no P waves. We're not seeing any smaller waves. We're just seeing this one giant gravestone of a wave. And so we really can't say that we're seeing a P to QRS. There's no interval. There's nothing really going on except for this gravestone, right? So we're going to call this monomorphic VTAC. With a pulse, hopefully, we're going to call it call for some antiarrhythmics or cardioversion. And if they have no pulse, remember we're going to defibrillate. This is not a good thing to see. This is very, very not so great. Okay. Now looking at this next one underneath that that monomorphic VTAC, what do we see? We see a streamer-like effect. It's using a pretty good portion of the strip. You can definitely see it looks like it flips. This one to me kind of looks like just something like crazy, right? And you can see it flip. Like there's that tiny part, and then it goes big, and then it goes small, and then it goes bigger. So I definitely say we can't really get a rhythm out of this, or a rate out of this, or really a rhythm either. I don't see P's that I know of, although like what is this little small stuff here? And I definitely see that these bigger ones have to be QRS. They're too big to be P's. But I really can't tell you anything about that. So I'm just going to have to leave those as variable and irregular. But looking at this, we know that this is VTAC. and we know that it's polymorphic because it doesn't look monomorphic like gravestones, and it does look like it has a streamer effect. So we're going to go points torsades on this, and or torsades to points on this, and we're going to know that it's different than coarse B-fib because it has more variability. We're having more of that twisting effect. And although this one's a little bit less exaggerated than the other one, if you're going to go back up to that page right before it with the coarse B-fib, note how it's still a lot more, there's no twisting, and it's a lot more monotone still. It's not the same as having the same thing happen over and over again. And it's still too big to be a P wave with the coarse, but it's staying within kind of a very like fitted area. Whereas this point's polymorphic VTAC is twisting. You should know both those names for it, by the way. I don't know which one could come up, but you never know. Okay. Asystole versus fine B-fib. Remember, this is a clinical decision. Okay, so we're looking at this and we're like, what is this? It's got a little bit of variability, and it's asystole or fine B-fib. We know that because we're not getting any of those well, first let's go with rate. Can I calculate a rate? No, I definitely cannot calculate a rate out of this. Okay, can I calculate a rhythm? Well, there's nothing really to like look at in terms of like little soldiers coming after one another. So I'm really gonna say that I can't calculate that either. Are there P waves? No, I don't really think there's P waves. If I don't see any really distinct looking waves that look like each other, if I was trying really hard, maybe I could try to make something. But there's definitely no like QRSs that are of any like substantial height. So, and it is a little bit less flat than I'd like to see for asystole. So this is a clinical decision, right? What is it? It's definitely asystole or fine B-fib. In terms of calling it, you're gonna have to make that decision, looking at the patient as well as looking at the EKG. This is a really bad sign, though. No matter what, this is not good. Oh, also though, with asystole, if you get asystole, you should definitely check your patient because sometimes like something could have fallen off. So definitely check to make sure that everything's there. Okay. Next, sinus with PVC. Premature ventricular contraction, right? So first starting off, do we have a rate? Yes. We see that there is definitely like a rate. Let's see what it is. 1, 2, 3, 4, 5, 6, 7. And we know that this is within a 6-second strip. So this is about a rate of 70, right? Also, the little lines on top really help because we can tell that each one of these is like 3 seconds. Okay. So now we're going to look at a rhythm. Do we see like one after another? Yes, we do in the beginning of the strip. 1, 2, 3, 4, 5, 6 normal ones, all at approximately the same length apart. And this strip is going too fast to be bradycardic, so that's good. And we note that there's this one crazy one. So we're just gonna have to say like the first part of it's normal. We definitely have a P wave, and we definitely have a P QRS interval, and it looks like it's within a good range. 1, 2, 3, 4. 1, 2, 3, 3.5 there. 1, 2, 3. I'd say that's 3.5 again. All of these are within like a good range, so we're gonna be good with that. But that one weird thing is that PVC. It's a premature ventricular contraction. We can tell it literally doesn't have a P wave that we can see really, and it's big and kind of like an S shape more than like a spiky thing, just like we'd expect out of a PVC. There's only one though, so it's not a triplet or anything. So we're just gonna mark that as a PVC, and let's move on to the next one. Okay. This one looks really, really crazy, right? Just looking at it, it's very regular, right? Does it have a rate? Yes, I would say it has a rate because I can count this, right? So I'm going to count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. 180 if we times that by 10. So this is very fast. That's much faster than what we consider like sinus rhythm, right? So because of that, we're going to count this up as definitely tachycardic. Is there a normal rhythm? Yes, this is very regular. They're coming at regular intervals. We can tell that. We can also count it if we want to. And we can look at the overall shape. This is very regular. Okay. Do we see P's? Yeah. I guess like this one is maybe a P, maybe a T. But it's coming very fast, right? And so that's kind of messing it up. And then do we have a good interval? We really can't count that either, because we don't really know what's going on here, right? Just in terms of it's so fast. So we're gonna go with making sure that we know that there's nothing missing. And I don't think anything's missing here. I just think that it's getting covered up, right? But the ventricles are very much involved. So I'm going to tack this up as definitely tachycardia. I definitely see I have ventricular contraction. And so this is a speed that the ventricles are going at as well. So this is going to be supraventricular tachycardia. It's still a normal rhythm. It could maybe happen with like stress. And hopefully most of the time it's easier to look at than this. This is a really fast one though. Okay. Normal sinus. This is a normal sinus rhythm. Oh man, sorry, I should stop telling you that. Okay. Looking at this one that's below that, we're looking at 1, 2, 3, 4, 5, 6, 7 for rate, right? You know that we can count that just based on there's nothing missing with what we're looking at. So rate of about 70. And are they coming at regular intervals? Yes, they are. We can count this. Again, there's 4 boxes, very much so, between these ones. Again, I see about 4 again here. So there's 4 large boxes between each of them. So this is very regular, right? I see a P. I see a P with each one of these. It's distinctive, so that's good. And then I also can count the P to QRS. I see a QRS, it's happening, and the interval is about 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. But they're all coming at about the same amount, right? They're not getting longer, and it's not too big. It's not too wide. So everything chalks up as good here. So this is normal sinus. Okay, next page. What are we looking at here? Well, we have those normal QRSs. That's good. But when we're looking at trying to find a P wave, so we can try to count a rhythm here. Ready? 1, 2, 3, 4, 5, 6. Is what I would say that rhythm is. 60. But when we're looking at, is it regular? Kind of. There's a really drawn out period here. And the biggest thing that stands out though is we have no P waves, right? Like, or no like defined like this is the P wave. Like there's a lot of little tiny ones, right? Does it look sawtooth? Like does this look like we could put it on like and like saw through a board kind of thing? Kind of, parts of it does, like right here, but they're not the same sort of regular, exactly the same copy paste as you would see with atrial flutter. So, and they're smaller. They're still kind of small, and they're definitely not the same like shark tooth wave that we would see with atrial flutter. So, but we know that this is atrial fibrillation because it's quivering. We have way too many of them. That's what this has got to be. So we're going to chalk it up as that. Okay. Now, looking right below it, you can see atrial flutter. this one, when we compare them, it makes atrial fibrillation look even more distinctively atrial fibrillation, because you can see that the atrial flutter has a sawtooth pattern, and they all look exactly the same, right? They look like shark teeth. And so because of that, it makes it very distinctive A flutter. And the atrial fibrillation is like a smaller version of it that's less distinctly the same shape. For the atrial flutter, can we calculate a rate? Let's see, 1, 2, 3, 4, 5, 6, 7. So there's nothing missing either, so that's good. And they're coming at a very regular rhythm. And there are P waves, but there are too many of them. And so with that, we know that this is atrial flutter, and we can go 1, 2, 3, 4, 5, 6, 7 at a rate of 70. Okay, next one under atrial flutter. What are we looking at here? Well, let's start with the rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Times 10, because this is a 6-second strip, we have 130 as our rate, which is way fast. So what are we going to do about it? We're going to note that this is tachycardic for sure, whatever it is, right? Now we're going to look, is it normal? Is this a regular rhythm? Yes, this is a regular rhythm. Every one of these soldiers comes one after another. We can also like blur our vision and look at it, or we could count. This first one has about 2 boxes between it. The second one has again about 2 boxes, maybe a tiny bit more. We're looking at like 4 and 5. There's definitely 2 boxes between those again, almost exactly. And again, between 7 and 8, we see distinctively 2 boxes, right? And then all the other ones seem to follow the same pattern. So we can definitely say that this is a regular rhythm. Are there P waves? Yes, I see a P wave for each one. And then I also see a T wave at the end there. They look very similar in this particular one. But we know that there needs to be a T wave after and a P wave before. So that's pretty normal. It's just going really fast, right? And then looking at PR interval, we can count that. Let's count it in the beginning over here. 1, 2, 3. Okay, 3. 1, 2, 3. That's pretty good. 1, 2, 3. Still good. 1, 2, 3. Maybe 3.5. All of these are coming in at about the same rate, right? So we're not seeing any change there. It's not too long. This is sinus tachycardia. Okay. That's all for this. Let me see if I can't at the very end answer any questions you guys have. Do you guys have like any questions? I don't know how many people are still with us. Do you guys have any questions? Anything extra you want to go over? Sorry, this really hasn't been quite what I was expecting in terms of like what I would be able to share with you guys and whatnot. But at least we could go through some of it. Hopefully that makes it a little easier. See someone's typing. Do you ever recall knowing any symptoms about the rhythms for the exam? I will say I can't. I do think. Oh yes. Okay. I forgot to cover something. Okay, so you're gonna deal with these differently based on what they are, right? I would not say that you need to know, like, is this would you think that this is caused by like hypocalcemia or anything like that? You don't need to know that, but you might need to know that for the exam in the classroom, depending on what's on the slides and what's expected to be known for that lecture, which might have changed since I took the class. But you definitely do need to know if you need to like cardiovert or defibrillate. And then you also do need to know what is it called? Where you just have where the heart's not beating but you're still getting a rhythm. What is that called? Let me see. It's in your slide somewhere. Pulseless electrical activity. So PEA. So when you're seeing this in real life, what it will look like is you're looking at the strip and you're feeling for a pulse. And your patient has no pulse, right? That would tell you that whatever the strip says, that's all electrical, right? That's an electrical current in the heart. But if the heart is not beating, where it's not like the muscle itself is not contracting based on the electrical signals in the heart, then you have to remember that it literally does not matter because blood is not pumping throughout the body. So on an exam, it might look like above the strip, the exam question would say, normally it might say something like, I don't know, patient comes into the ER and is struggling with breathing or something, right? And, nurse hooks up patient to the EKG, and the EKG shows this, right? Well, sometimes if you're not paying attention to reading the question correctly, you can miss something important because maybe at some point it'll say something like, patient comes into ER, gets an EKG, it shows patient has no pulse and it shows this this rhythm. And so if you're just looking at the strip, then all you're going to see is, oh my goodness, it looks like they have, what about, they have something weird, like atrial flutter or something, right? And I'm like, ooh, I'm so excited. I can recognize atrial flutter, and it looks like sawtooth, and it's all regular, right? But the patient has no pulse. So that clears, if they have pulseless electrical activity, PA, that negates everything else that the patient has. Oh, did I just end it by accident? No, I didn't. Okay, good. Oh, I just hit something. Okay. If they have pulseless electrical activity, that means that whatever the strip is saying is irrelevant, and the heart is no longer pumping. So you're going to need to treat it like pulseless electrical activity. This patient has literally nothing going on, and it's really bad. Versus like not, you do need to know the strip, but at that point you don't need to know it. So always read the exam questions, and before you like look at the strip, just so that you know what's going on. And most of the time, in clinical, that would look like, on the NCLEX, that would also look like reading the full question and looking to make sure that a patient has a pulse. But in terms of in real life, in the ER, you're looking to make sure the patient has a pulse by actually feeling for a pulse, right? Okay. Yeah. Okay. I don't know if you need to know pulseless electrical activity, PA, what to do for that. Let's see. If it's not, it looks like it only is listed as PEA. So asystole and pulseless electrical activity. Let's see, pulseless. Okay. Oh, here we go. Okay, on the slide, it shows slide 2044. And that shows like where it would say something like above the strip, and then you need to look at it, right? Look at the actual strip, and it looks like a nice strip, but it actually is nothing's going on. It's also called electromechanical dissociation, or EMD. All right. It doesn't look like you're given any. I may be wrong, but it doesn't look like you're giving a real intervention for that. They may have said in class, I believe you're supposed to give them CPR. And then I'm not sure that you can shock this, just because there's like It's not listening. What would you say you must know for the exam? I would say you must know how to look at an EKG. Because first you must know how to read questions, right? Because you need to be able to catch like your patient doesn't have a pulse and whatnot. And then you also need to look at which rhythms are which. And I'm going to try to send out this sheet that has like simplified versions, but as you get better at looking at it, it won't be as hard to identify. So you're going to need to know not only like, oh, I can tell that this is points to Dersades de points, right? Or I know that this is ventricular fibrillation, like monomorphic, right? Or monomorphic VTAC, right? You're going to need to know beyond that. You're going to still need to know how to go through this process because they're also testing you on how to go through the process, right? So what would be the rate? What would be, is there a normal rhythm? Is there, like, how long is the PR interval? All that information just in terms of, like, being able to fill out one of these questions is kind of, like, sort of what you're looking at here in terms of, like, studying for your exam. I would also know the normal conduction pathway and, like, what is a normal rate? You know what I mean? But they're not going to test you on like something that you have no that they were not like that they weren't really talking about while they were looking at these EKGs. Like while they may test on like therapy in this exam, because we need to know how to look at a strip and not only identify what it is, but intervene in really bad situations, right? So we need to know like when to defibrillate and stuff like that. We don't need to know like is it low magnesium or like do you think this was caused by heart failure or COPD or something like that. Like this is not where you're trying to like draw in like background and such. I would just study the study guide and really know how you're going to work through it yourself. Like by yourself, sitting there, working through the different problems is really going to be like, I think, your best way of learning. I'm sorry. But I would also like, I don't know if Simple Nursing has his videos on YouTube. But there's some easier ways to identify these rhythms just in terms of like looking at it from an overall standpoint to be able to identify things. Let's see what else. I would say must knows for the exam are honestly like I don't want to say all of these rhythms, but I think it's all of them. I don't know if they said that they weren't testing on any of them. I believe in my year they might not have been testing on some of the blocks. I can't remember which one it was though. But I would not go off of me in terms of that. But really, when you're looking at this, like you're learning it for clinical practice, so it'd be good to learn all of them. And then this is also like to help you. So think about it kind of like a math problem. Like go through the steps. Don't skip things. Make sure that you're really understanding like how would I approach an EKG strip if I was given one, like just in general. And then you're going to do really well. I think you're going to do great. Does that help? Okay, I'm glad. Sorry this hasn't really been like as easy to follow along as I was hoping it would be. I need to work on figuring out how to get just like my PDFs and such to show up on Teams. I'm really sorry about that, guys. But thanks for sticking with me through it. And if you have any other like extra questions, you can email me. If you have my number, you can text me and we can run through stuff. I know EKGs are super scary. They're not as bad as you're thinking of, especially if you've taken OB already. You're thinking like, oh my goodness, this is an OB strip. It's not an OB strip. I never really figured out how to do OB strips very well. It was really hard for me. but EKGs, once you like understand like how would I run through this kind of like a math problem, and you understand like you can count boxes and you can look at it, and just generally like looking at patterns and such, it's a lot easier in my opinion than OB strips, and you're gonna be okay. Yeah, but I really hope that helped, and you guys are awesome for sticking with me through it. And I can't wait to see where that goes. So best of luck with your EKG stuff. Do you have any more questions before I leave? Okay. Bye, guys.